Are you guys seeing the main presentation slide?
Yep.
Or are you seeing the presenter view? You're good with just one slide?
Yep.
Okay, well, Zoom tricks me sometimes. It doesn't quite tell me exactly what it's sharing. Thank you so much for having me today, and it's exciting to be here with this group. So as Matt said, what I'm going to talk about today is an addiction consult team that we're launching at Michigan Medicine. Usually when I talk at Michigan Medicine with our care teams about this work, I start with all the stats about opioid overdoses being on the rise and how they've increased, 20-odd% during COVID. This group, I do not feel I need to do that with. You guys get that context. What I do think might be interesting to share with you is some data analysis we did just within our own care system at Michigan Medicine. We looked at who were all the patients who interacted with our care system in different ways, who either had some kind of opioid use disorder diagnostic code documented on their chart during that year, whether or not that was the main reason for their visit or not. And then we looked at how many times did they come get care from us? How many times did they come to the ED or get admitted to the inpatient hospital or come to outpatient clinics? And we share this internally as we talk about this, because a lot of people say, well, we don't have these patients here, quote unquote, and all of you know better than that. This is a disease that impacts a huge number of people. It could be co-occurring with other things. And this is some data. This is our baseline, right? This is the floor, because we know we're not diagnosing this in everybody. This is just people who did actually have some kind of diagnostic code. And we like to share this to show, for instance, in our acute setting, if we think about either people who came to the ED and went home or who were admitted to the hospital, many of whom also come through the ED, it's almost 3,000 people in the year who came through our doors in an acute crisis mode, and for whom we were able to do very little with the setup that we had in any specialized way to help address their opioid use disorder. Another thing that we've kind of tried to take care, and again, this is a group to whom this will not be a surprise, but we're in some of our patient focus groups and discussions that we've tried to have with people who've intersected with our system with substance use disorder. I think there's a couple of quotes I wanted to share here. One is, everything can be great until they read your chart. And as soon as they see substance use history, even if it's a decade or two old, they're going to immediately worry about you being a liability rather than a person who they treat. The second one, which was also, the stigma one was not as surprising to me as this one was. I've been with my sister many times when she's had surgery and she actually has to explain what she's addicted to and what kind of medication they can and cannot give her, and what kinds of things will trigger her addiction. This should not be up to the patient. Yes, she has to be vigilant, but it should not be her job to teach the doctors about medication use. I think, yeah, again, this is an audience to whom this maybe is not as surprising, but when we share this with our care teams across the system, I think it causes them to pause and realize, well, yeah, maybe I should know a little bit more about this as a medical professional than the patient that I'm treating. So in terms of why start an acute care addiction consult team, as we looked at that data, we saw how many people were coming. Obviously, a lot of systems, including some of the people here today, have been involved in this for some time, and are well aware that hospitalization offers that opportunity when people are in an acute setting to initiate and coordinate care. There's been a lot of studies that show initiation, particularly of medications for opioid use disorder in the hospital, improve dramatically the follow-up by patients. If they can consult with a specialized team, they're much more likely to engage in some follow-up in the outpatient setting around their substance use issues. And then if they do get robust outpatient treatment, their chance of being rehospitalized reduces. So we kind of see this, this cyclical reinforcement where we start to move people away from always having to receive care in an acute setting in crisis mode to having a more community-based, outpatient-based care model for their disease. So we began launching this service in in April. At the moment, and Eve has been instrumental in this, we pre-launched in the emergency department in particular with a social worker who some of you will know, Emily McCall, who had a long and wonderful history with Michigan Opioid Collaborative as well, and with some pharmacy connection as well. And within the next couple of weeks, we hope to launch the full service with an attending provider who's joining us from another system in Pennsylvania, where he's run services like this for a number of years, as well as a peer recovery coach who's starting next week with us. So this is the kind of roles I just sort of started to talk through that will be involved. And we're also planning to involve a lot of learners and other things. I think one of our big goals here is to try to normalise care for this disease across really all of our care teams and all sites of care. So we felt it was important to make sure we connected this with some of the other education missions of Michigan Medicine, and had an opportunity for as many fellows and residents and students who want to rotate on the service as possible to do that, so that they can begin to get more familiarity, not be the doctor that has to be taught by the patient, whatever specialty they end up in. This is perhaps a kind of the best for you to speak to this a little. This is just an infographic we pulled together that tries to show how all of this care fits together. So we have this addiction consult team up the top here, which will see patients, engage with patients in the emergency department and inpatient setting. And we are trying to work this across both the adult and pediatric and obstetric space, recognising most of the volume is in the main adult hospital, but there are, our social worker actually had her first consult from the Children's Emergency Services last week for a young adult who she was able to connect with care. And so we want to make sure that the service is available for anyone who needs it age-wise. And then we have really, once the acute care setting has been, if they're intersected here, then we have a couple of people, our social worker on the ACT team, as well as this role that we initiated right at the start of COVID last year, actually, right before that began, a person who is helping manage patients in primary care with particularly who are on medication for opioid use disorder, and to help coordinate care within our primary care clinics. I'll speak a little more to that in a moment, as well as UMATs, obviously, and external PCPs and community partners who are such a critical piece of this picture. And really our goal with all of this is no matter where a patient enters our care continuum, we want them to be able to get connected with the treatment and support they need. And as I said, to try to normalise care for this chronic disease across all sites of care. One thing, this is something we share internally as well, and again, this group will understand why. We really struggle with what to call this service. It's ultimately, we want our care teams to engage with the service and to know what they're looking for. And we were a little concerned if we called it the SUD service or the substance use disorder service. That's just not where most providers are right now. People are used to this being called an addiction consult team. That's what most other places do call it. But we're trying to train our internal teams to refer to it as ACT or the ACT service. Or ACT team, we just get over the double T thing, mostly because we want to be inclusive of patients who could benefit from some of this service, but who may not identify themselves yet with having an addiction or SUD, especially some of the chronic pain patients that we see in our system. So this is just something we're trying to internally level set around. And then here you see the objectives for the service. So one is to encourage appropriate medication use where medication is appropriate. And then our kind of big goal is to connect patients with an outpatient provider who do begin treatment for longer term treatment within 3 days of hospital discharge. And we've been working with our primary care clinics and Packard, and we'll be kind of gradually working more with some of the other community partners in the coming weeks and months as this actually comes underway to make that a reality. You're all well aware of the resource limitations in this space, so that's really been one of the things we've tried before we launched the service. That was the thing we were trying to work most proactively on, is how can we make sure that we can get that follow-up that patients need. And then, as I've spoken to already, the education elements and really just working across the care teams to reduce stigma towards patients with substance use disorder and to reduce treatment disparities. One thing that we found in our data analysis, which we put very front and center with a lot of our health system leadership, was that when we looked by payer across, we could see that all of the vast majority, over 70% of the patients that come into the acute care setting with a primary diagnosis of substance use disorder are Medicaid patients, and over 70% of those with a primary diagnosis in the outpatient space are commercial. So just trying to think about, how can we tip the scales so that for those who are the underprivileged people that we're serving, that we don't continue to just treat their chronic disease in the acute care setting, which is not good for them, and not something I think that there was a much visibility to until we started sharing that data. So that's something that we really want to try to work on as well. One thing that we, actually I'll quickly speak a little to the scope. Obviously this is an opioid project group, and we do have some grant funding which is focused on opioids and MOUD. So whilst we are kind of buprenorphine initiation and management and opioid use is definitely one of our focus points, we have been really mindful about not limiting our services to that, because it's somewhat naive to think that we could, particularly with so much of the polysubstance use that we see within our patient base. So we also will help consult on some of the more complex alcohol withdrawal or complex prescribed opioid management, as well as stimulant use and other. We want to be inclusive and be a service that says yes rather than not our problem, because I think this patient base and the providers who try to get help for these patients have had enough of, this is not our problem. That's what most people say. So that's really, we've tried to keep it broad deliberately, whilst also recognizing that this is going to be a small team to begin with, and there's only so much they can do. So we want to try to balance helping everyone we can, but also putting the resources where they can have the most impact. So that's something that will be a challenge as we go on, I know. I wanted to share this just as a snapshot. Before we even launched the consult service, and this was linked in part to some of the Blue Cross Blue Shield incentives that had come out in the last couple of years, but we began in September 2019, really trying to aggressively work with primary care to increase the waivered providers and those who were actively prescribing. And thanks in large part to our family medicine department, who took a very proactive approach to this. They took time at various meetings to get everybody waived, and I've been doing some other work there. Plus the care coordinator we have initiated in primary care. We've more than tripled since September 2019, the number of PCPs who are actively prescribing and the number of patients who are receiving this treatment in primary care. I like to think these would be even higher if not for the fact we basically lost a year to COVID. So despite COVID, we were able to keep some of this momentum going, which I know particularly family medicine is proud of, and it feels like we're just starting to hit that tip of normalcy of normalization of this treatment in primary care, so that hopefully then others around them will begin to feel more comfortable. The final thing I wanted to share is just a kind of broader view, again, which we share internally here, of really we see some of this work as hopefully catalysing broader system-wide changes in the way we handle substance use disorder and pain treatment. So we're focusing at the moment on the inpatient treatment as that kind of tip of the iceberg of some of the most acute patients. But then really wanting to help revamp the way we treat this in partnership with pain clinics, primary care, UMATs, and of course community partners, none of this. The community is where patients live, right? They spend a minuscule fraction of their time intersecting with healthcare providers. And so for myself, I feel like we've had some work to do to get our house in order and to bring our standard of care up to what we think it should be and what, you know, some other systems have been doing for some time. I think I own that. We own that as a system. But I think the next step as we start to develop that internally, we would really like to continue to bolster those community partnerships and work together to do the best we can by this patient population. That's all I've got. I'm really happy to take questions or have any discussion people want to have about what we're doing or how people would like to collaborate. So there's a question from Ashley, I see. What services, would services be provided such as safer use education and supplies? I'm very glad you asked that, Ashley, because we're actually, I'm in the process of having some conversations with our risk management and other folks. So we'd like to get Emily a nice big backpack of harm reduction supplies that she can walk around the hospital with. She's certainly been providing some flyers that she had picked up from Unified, but we're hoping to actually get some other supplies specifically. So once I've gotten an all clear from our risk folks, we were actually planning to reach out to you, Lamont, and see if we can organise something.
That's awesome to hear. I know you said that the pre-launch is kind of happened around April 12th. Were there any kind of like unexpected barriers or what has been the most challenging thing that you've seen so far in getting this up and running?
Yeah, that's a great question. And I'll let Eve chime in too on her thoughts there, since we did really start this in the ED. I think one is just starting to get the word out, right? And encouraging a different kind of conversation. So one example I can think of that I know took our social worker a lot of time was pretty much like day 2, I think. There was a situation where a patient had come in, she was found with some illicit drugs in the hospital, so nursing freaked out, they called security, police come, the person leaves against medical advice and is incredibly sick. And then the next day our social worker got in there, realised that she had left, and actually really engaged with security, engaged with others, and engaged with the patient and her family, and got the patient back in. She was really at risk of dying if she didn't come back in for multiple reasons, not just connected to her substance use. So I think that was, it sort of really brought home for us right up front that there are so many people and so much complexity too that comes from some of this disease being criminalised that I think has been one challenge that kind of came front and centre even quicker than we expected in that first week. I think another challenge is just is that you can't change everybody's perceptions and stigma and comfort level overnight. And Eve, I don't know if you want to speak a little to that from the ED perspective.
Yeah, I mean, I think as far as soft launches go, we've had quite a bit of success, and our nurses are getting education on stigma reduction, harm reduction, general OUD, and then BUP for OUD. So we're slowly kind of rolling things out, giving them information kind of piecemeal, because nobody has an hour to listen to a lecture. And so it's daily reminders, it's weekly mini lectures, and we have a nurse champion who's doing that. Emily is working with our social work team, which is huge because they're coordinating and they're helping each other and they're learning from each other, which I think is really fantastic. The providers are getting on board. I think I've told this group before, but we now have almost half of our adult providers who are waiver trained. And once we have an order set and the workflows, all the kinks are worked out, I think we're going to see that people are willing to go ahead and prescribe. One of the barriers that I anticipate, one of the challenges that I anticipate is The ACT service is a 8 to 5 service at this point, and it's not available on the weekends. The team has set up a system where Emily gets alerts on every single patient who is seen for OUD, every single patient who is screened for SUD by social work, so that she can follow up the following day. But for some of our patients, we need to be there in the moment. And so that is why the coordination between Emily and our kind of embedded social work team is so critical, because I think that what we're going to see is that our social workers, who are already very expert, are now going to have a much more nuanced approach to patients. They're doing a lot of kind of behavioral interviewing, like how do you modify that for a patient who's kind of pre-contemplative around recovery. And, you know, I mean, there's always room for improvement. There's always room to do this better. And I think all of us are going to learn a lot over the next few months. So yeah, stay tuned.
Mm-hmm.
That's really exciting to hear. So I guess I want to follow up on the with one last question here as we wrap this part up. What do you think some of the biggest things that community organizations can do to kind of help you know, organizations like the Opioid Project to help make this a success?
Yeah, that's a great question, and I've been thinking about that quite a bit. I kind of like to hear from others here who participated in this. I mean, but I feel like as I've gradually gotten more immersed in this world, and you know, seeing this with the vaccine work that Juan and I have worked on too, I think there's opportunities just for the health systems and the community partners to probably just talk more about what's going on. And I mean, it's as simple as that in some ways. I think too about, you know, how do we try to work together on some of the gaps in, you know, for some of the payer populations and other things. I know that's something we've been struggling with, and I keep asking literally every week, why can't we reconsider some of those things around, you know, UMATs and Medicaid, and like, I think just questioning some of the assumptions of why it's always been done the way it's always been done. I think is something that would be healthy to do as a collective group. And I know you guys started some of those dialogues sort of pre-COVID and around some of those, you know, third rails, like birth month and you know, those sorts of things. But it's, and so I don't know where your work is at too. I'd be interested to kind of learn where that's at, and whether now kind of in our post-COVID or, you know, ongoing kind of world, whether there's sort of a chance to look afresh at some of those things. Jacqueline, thank you for the comment there. We've talked a little to Mark Weiner about the wonderful work that you guys have done and early on, and learnt from that definitely in how we've designed some of this. And from the way you guys use Sunday as well appear there. So.
Well, thank you guys so much. I know Eve and I have briefly talked about, you know, making one of our upcoming educational webinars about some of the work that's being done both at Michigan Medicine and St. Joe's. And so we'll be excited to hopefully get a date in the near future set up, and we can do that as well. So thank you so much for joining us.
You're welcome. Thanks.